Thank you.
Thanks.
Hi, everyone. I'm Robin Pierce, Senior Brand Manager at LASA OMS. Thank you for joining us for today's webinar, Ask Me Anything, Sports Acupuncture, featuring a panel discussion moderated by Whitfield Reaves. Before we dive into tonight's content, let's quickly get acquainted with the webinar room. You'll find two tabs at the bottom right of the screen, Questions and Chat. Use the Chat tab to connect with the fellow attendees, notify us of any issues. For questions directed to the panel, please use the Questions tab. These questions will be addressed during the Q&A session at the end. Remember that this webinar is recorded, and after it concludes, you'll receive a link to watch the video on demand and access the presentation slides. Let's meet our moderator and panelists. Our moderator, Whitfield Reaves, has been working in the field of sports medicine since he first began practice in 1981. He's the author of the Acupuncture Handbook of Sports Injuries and Pain and teaches his well-received apprenticeship program. His online CEU courses on diagnosis and treatment protocols are available on our website. Dr. Jenny Nieters specializes in sports medicine, orthopedic injuries, and athletic performance. In addition to her private clinical practice, she's an acupuncturist for the San Francisco 49ers football team and the St. Mary's College rugby team. Jenny co-teaches the apprenticeship program with Whitfield Reaves. Vincent Koeller is a licensed acupuncturist and has studied advanced courses in Chinese medicine in both Taiwan and China. Specializing in sports injury and pain, he's on staff with the University of Southern California's athletic department. Vincent assists in seminars taught by both Whitfield and Jenny. Derrick McBride is a licensed acupuncturist and certified strength and conditioning coach. He has extensive training in orthopedic testing, functional movement, and corrective exercises. He has over a decade of experience working with collegiate and professional athletes. Derrick's innovative seminars and online CEU courses integrate these orthopedic practices with acupuncture and Chinese medicine and are also available on our website. So without further ado, I'll pass it over to the panel.
Okay. Can you hear me?
Yes.
Okay, good. Everything is just fine here. We had some technical problems. So our whole purpose of this webinar, of course, is service to the community and service specifically to sports acupuncture and anatomically based acupuncture. And I'm sort of the moderator, so we're going to be hearing from my three colleagues here on a lot of different topics. But please understand that we want your questions. And to start, we're going to start answering questions that were sent in early, pre-webinar questions. And I'm going to very briefly start with the first one because I think it's interesting. And one of them was, is treating trigger points the best way to proceed in a sports acupuncture practice? And we all know how widespread dry needling is, trigger point therapy, all of these different offshoots of this. I personally studied with Janet Travell, who wrote the books on this in 1979 or 80 or 81. I can't remember, a long time ago. And it changed the way I looked at acupuncture and how we proceed. But I want to basically caution or just kind of bring up the point that we have a medicine that treats the body, mind, and spirit as a whole. So with every patient, we need to look to see what needs to be done. And we don't want to rely on just one thing for everything. The body is much more complicated. Medicine is more complicated. The interactions of the muscle and the neurologic system and the endocrine system, so complicated. We need to have lots of different tools. So in sports acupuncture, if we're thinking of musculoskeletal, with sports acupuncture, I think it's important to understand that Trigger points are important when they are the problem. When there is an area of stagnation in a muscle that causes pain, that refers pain, that causes the muscle not to function correctly, doesn't contract and relax correctly. It might inhibit, it might tighten and contract, but whatever it's doing is not so good. But suppose the problem is in the tendon or a ligament or in the joint capsule, or suppose it's a fracture on a bone, it's a periosteal bruise. We have all of this wonderful continuum of anatomical tissue, and we go to where we need to go. So the muscles and treating stagnation in a muscle is literally just one part of sports acupuncture. It's one technique, but please don't ever get into the habit of thinking that all pain is generated by muscle and all pain is generated by trigger points. I think you'll find yourself at a disadvantage on many cases. So, that being said, we want to present a number of different types of treatments and talk about different ways we go about treating injuries. And of course, we want to continue to answer your questions. So there is a question place here. Write it down. Those of you who are used to Zoom, it's a little bit different, but we've got the chat would be a fine place for you to write questions if that's it. But let us proceed. And I'm not going to look back into the chat any further than where we are now. So if anybody's got a question, please write it fresh now so we don't have to go back. There's a lot of hellos and what have you. And that's great. We're a community. We love being with each other. And so here we are together. And Jenny, what do you think? Do you want to start and
Sure.
One of our treatments you love?
Absolutely. So one of the questions that came in.
PowerPoint.
Sure. Yeah. One of the questions that came in was, how do you treat iliotibial band syndrome? So the iliotibial band is like a thickening of the fascia lata that wraps around the leg, that goes down the lateral side of the body. So for us acupuncturists, you can think of this as Shaoyang. So for me, there's a lot of tissue that's investing into this tight iliotibial band that then can compress and irritate nerves underneath it and cause a lot of pain and stagnation. And so I think Whit's going to pull up a pic for me of this lateral line of the body. Yeah. So we're looking from the side. This is Shaoyang. And what you see at the top of the hip bone attaching to the top of the femur is your gluteus medius muscle. And this muscle tends to get inhibited. And when it does, the muscle right in front of it, the TFL, tends to just try to be a helpful neighbor. And you can see right where in the area of gallbladder 29, just in front, you can see that TFL. And this helpful neighbor tensions this IT band and can cause thickening. And it can just be your overworking neighbor. So some people feel that treating the TFL is a big piece of the tensor fasciae lata muscle in that region of gallbladder 29 is a big piece of treating the IT band. But for me, my perspective is that's more the branch, and mostly I want to treat the root, which is inhibition of this gluteus medius muscle, which is the major stabilizer of the pelvis when you're walking. So the way I do that is at this master point, Jen Kwa, that we just saw. But we can see when you're walking here, this is on the left side. We have a strong gluteus medius. The weight has landed on the right leg, and the pelvis is relatively level as the opposite foot is going to swing through. And this is something we can do. We can watch people walk and see what happens. And if their pelvis, when they land on one leg, remains relatively level, then we can think, okay, that glute med is probably healthy and strong and functioning pretty well. But sometimes we're going to look at them and we're going to see the opposite pelvis drop down. And that's this Trendelenburg posture or gait. And we can test this just by even having someone just stand on one leg and balance. And that's the opposite side. We can also test it by just having someone lift their hip up to the side and push down. We can see if they can hold it up against gravity. This is hip abduction away from midline. And so this is a test to see if that can fire and engage. We can add a little pressure and try to press it down and see if it can respond to that pressure. And so that would be a resisted hip abduction or a manual muscle test. But really, you could just like this. I like to touch above the knee instead of down at the ankle, because that leg is a long lever, and legs can be pretty heavy. And if someone has pathology in their glute muscle, like a tendonitis, this test could be pretty provocative and painful. So or a knee issue, it's gonna, immediately kind of give you a provocative response. So those are simple ways you can test this. And you'll be surprised at how many people have weakness in these muscles. People who look like and are Olympic athletes can have inhibition in these muscles. So people whose bodies are, like looking like Greek gods can have inhibition in these muscles. You can have inhibition in this muscle, and I'm not in that category. But anybody who spends time sitting, in meetings or sitting in chairs or sitting at computers, very often will have weakness in these muscles. And one of the ways that you can just really very simply treat this and disinhibit this muscle is to treat this master point, Jian Qua. Now, this tissue of Jian Qua, it's going to also connect to this IT band a little bit more indirectly. Glute Max also has a piece investing into this IT band. But if you restore function here, you're going to take a lot of pressure off the whole system. Now, the other piece is sometimes down by the knee, a person with iliotibial band syndrome can present with lateral knee pain. And a lot of these patients will say, oh, I must have done something to my meniscus. And maybe it's really not the meniscus, but if you compress that IT band against the lateral femur, the condyle of the femur, and it's painful, it's a good reason to now add a couple more points. And those points, I like to just slip under that portion of the IT band and add a little stem. So for me, Jian Qua is the key to iliotibial band syndrome. And then you can see, just looking at this IT band and how Shaoyang it is, we also have those points that are gallbladder 31 and 32, just midway in that region. And we could also add those points too as adjacent points. And because we're acupuncturists and we're going to be looking at the whole kinetic chain, we can also think of some distal points like gallbladder 41, if that palpates as tender. Gallbladder 34 can palpate as tender. So for me, based on palpation and then also thinking about the anatomy, I might add gallbladder 34, gallbladder 40, and potentially even more distal. So just don't throw out the baby with the bathwater. Like, you're treating the anatomy, but we also have Chinese medicine. So you could throw in an opposite Shaoyang hand point if you wanted to be elegant, and maybe a Sanjiao 5 or Sanjiao 3. And maybe you're thinking it felt dry and stringy. Maybe you're going to do your opposite liver 3 to nourish the sinews and think about the blood for this person. So I think that's it.
Very good. Very good. Now, please understand that we love this treatment that Jenny just talked about. We use this all the time for lots of different things because the pelvis needs to be stabilized. So when the pelvis does this, not much good's going to happen in the lumbar spine and the sacral iliac joint, the hip joint, the knee, the foot, all the way down. So pay attention to that treatment. Very useful. Perhaps our second most favorite treatment that we as a group tend to really enjoy is treating the supraspinatus. And Donna has the question, suggestions on treating bursitis, impingement of the shoulder. So, Derrick, do you mind if I give this one to you? Because I know you love this and you have stories. And by the way, your questions are wonderful questions. We'll try to get to everything that we can. So keep the questions coming.
Yeah, supraspinatus. I've told this story many times, so some of you may have heard it. But subacromial impingement of the supraspinatus tendon, which we're seeing here, coming across from SI12 down to LI15. That tendon will get impinged between the acromion and the humerus. So that's the supraspinatus tendon, and there's also a bursa that sits underneath the acromion there. I came into acupuncture from the sports medicine world. And classically, in the sports medicine world, this is a very difficult thing to treat, right? The way that we can treat it without using needles would be like electrical stim pads around here, maybe some ultrasound, use lasers, but nothing really gets underneath that acromion to that space right between there that will create that impingement and create that inflammatory pocket right there. So I was working at a sports med facility. This is a good visual here of especially like how we can place those needles. But I was working in a sports med facility in Santa Barbara. Planned on going to physical therapy school, was talked out of that for a number of different reasons. But we had some shoulder impingement cases. Again, we were working with these patients 3 times a week for 2-3 months on end, and still like a lot of times go up overhead and still get that pinchiness through there. And then we had an acupuncturist that rented space from us, and my boss would refer to him every once in a while. And a lot of times it was for shoulder impingement. And within 2 sessions, patients were 80% better. And again, that doesn't really happen a whole lot in the traditional sports medicine world that I had seen. So I started asking questions, and I was shown this treatment that I later learned from Whit, and that was kind of what set me on my acupuncture journey. But we can thread needles into this subacromium space. You kind of start at LI16, and then you can kind of bump back, maybe a half a soon. So you've got a little bit of extra like runway there to be able to thread it under the acromion and under that distal attachment at that AC joint. You can run that under that bony structure out towards LI15. You can place another needle. Many times here, I'll do 2 paired needles at each point and then run electrical stim between those. And there's nothing that can get into that space. Us as acupuncturists, if we can understand the anatomy, we can understand our tools, like we are going to be able to help this condition better than anything that's out there in the sports medicine world. A prime example of that is actually just last week, I believe, last week or the week before. I started at I'm newly back in Pittsburgh within the last year. So I'm working as a contractor at a spine and sports center, and they sent me a 16-year-old volleyball player. For 2 years, she's been dealing with this pain overhead when she goes to serve. They got the scapular mechanics down. They've built strength within external, internal rotators, all the classic stuff that they're looking to do. And they still could not get rid of just a little bit of pinchiness. And if she served for like a full match, she would always have like residual pain for a few days afterwards. And in one session, I saw her for about 20 minutes. I did 2 points at LI16 threaded under that acromion towards LI15, 2 points near LI15, ran electrical stim, had 1 distal point down on small intestine 3, We're on this large intestine. There's like using points within the large intestine, but the supraspinatus is within the small intestine meridian. So I'd use SI3, and in one session, all of the pain was gone for the first time in 2 years. The next time she went out to play tennis. Treat her one more time. Again, they've been working on scapular mechanics and all of these things that generally will contribute to creating that impingement pattern, which is kind of like the next step of things. But no one within this facility could get to exactly where they needed to get to. And all of my practitioners I worked with were really excited to see the treatment and see the results. And if we're able to explain it to them in ways that make sense to them, or it's like, no, I'm getting right to that space that we're trying to get to, where there's that local stagnation, we can lay needles very nicely. Again, 16-year-old patient, she barely felt anything during the treatment. It was not an uncomfortable treatment for her. And we were able to knock out the pain for the first time in 2 years there in that overhead position. Really, really fun treatment there. And yeah, again, it was the one that kind of like brought me into the sports acupuncture world. So I always love
Excellent, Derrick. Excellent. Listen, somebody is typing and we can kind of hear the rattle. If you could mute your microphone, maybe that would be helpful. So supraspinatus, Derrick tells a great story. We've all got these stories. I feel sure that he also included small intestine 12. He was talking about the exact tendinous area that's impinging, but we'd love to go to the muscle belly. So undoubtedly, Derrick used 1 or 2 needles into this zone of the muscle belly, which happens to be where the trigger points form. It happens to be where the motor point, where the motor neuron enters the muscle. And interestingly, small intestine 12, Chinese name, Bing Feng, it's a wind point facing the wind. It's Feng is wind, as we know. And so what is the wind in the shoulder? It's impingement. It's sudden onset, sudden disappearance, radiating, moving, on, off, changeable. And so the Chinese got this perfect with using small intestine 12 to take wind out of the shoulder. They weren't describing the anatomical situation of the tendon being impinged by the bone. So wonderful treatment. And Derrick, while you're here, maybe you could make a simple explanation of a question that was sent in. Is that the question is there reason to determine points based upon the myofascial chain? But let's try to keep this one simple if possible, because we can go to town on this.
Yeah, we could definitely go to town. So I kind of mentioned a little bit there using SI3 as a shoestring point of the small intestine channel, corresponding more towards the supraspinatus. So there's an example there where, the pain that this patient's going to feel is going to present very large intestine channel, but using orthopedic testing, arc of pain test, and then we went into Hawkins-Kennedy tests, and these tests that are trying to figure out where that local anatomical stagnation was, able to determine it was actually more within the small intestine channel. So that's what drove me to use that point. Another great example, more on like the more myofascial chain, I guess, would be like a hamstring pull. I always end up going more like gallbladder 34 as a distal point for a hamstring pull. Many times, especially a belly hamstring pull will be, really felt at that like UB 37 area, and you can palpate that right in the center of the belly. Many times it's going to be painful, but if you stick 2 needles there and hook it up to stem, which is generally the way that I'll treat that, you're going to see that twitch. You're primarily hitting biceps femoris. You're mainly hitting that lateral hamstring, and you're going to see that twitch go to the distal attachment of the lateral hamstring. And the lateral hamstring attaches to the fibular head. If we think of through the spiral fascial chain in particular, from that lateral hamstring to the fibular head, then down to the peroneals. And I'll say this, but try to not go too far deep into it. A lot of times the control, kind of what Jenny was talking about too, of that like hip stability in this Trendelenburg gait comes down to like the stirrup of the foot and the stirrup of the knee, internal rotation of the knee, of that tibia, controlling that, internal rotation of the hip, controlling that. So here's an example of the spiral chain and like the control there, where, you know, the pain is going to be felt within, and a lot of times you're going to be treating within that urinary bladder line. But I like that distal point, especially for the lateral hamstring pulls, going more into the gallbladder line because of that fascial connection from that lateral hamstring down to the peroneals there.
Great. There's so many questions. Jenny, I think that you could give an example of that's very easy for all of us to see, of the posterior chain in your 2-point treatment that you do with professional football players before events, where you target the hamstring and the calf. Maybe you could just mention that and that's a more easy to see, that posterior line. And
yeah, so a very simple treatment. I actually learned this when I was working at the Rugby Sevens tournament in Las Vegas. One of the refs ran off between games and said, "Oh, my legs are feeling so heavy." And all I did for her face down for like 15 minutes was bilateral bladder 37, which is between the hamstrings, midline. And then also bladder 57, which is gastroc soleus muscle tendon junction. And so just between those two gastroc heads, just those points. And she took off. And then the next thing I know, she said, "Oh, my legs feel so light." Next thing I know, all the refs are coming over. "Please, can you do whatever you did for her?" And then since then, I have repeated that a lot. And it's very much appreciated for people whose legs feel heavy pre-game, pre-performance. So yeah, it's very simple. Just using that Taiyang posterior like fascial line. So that Tom Myers shows in his work, and it's very useful.
Very good. Thank you. Thank you. Daniel asked the question, going back to the supraspinatus, are you using E-stim between LI16 and LI15? Or are you using the pointer plus on only LI16 ? There are numerous ways to do this. I would think that the pointer plus to stimulate the muscle itself. This, by the way, is available at LASA OMS, and we use these a lot. Usually, you like to use that going into a muscle. So I would tend to think that would be used more commonly in small intestine 12, because that's where the motor point is, the muscle belly. You could use E-stim between LI16 and LI15. That's common. Sometimes you have 2 needles into LI16. To get 2 needles under there, you may use E-stim between those 2 needles. So there's not an answer to your question, which I think is a huge relief, because there's lots of different ways to do it. Once you get the feel of what you're trying to do with the anatomy, there's a number of different ways to go about doing this. So it's not so fixed that it has to be a certain way. And we do have a question about E-stim, how to set it up in terms of your components of cadence and what have you. We'll get there. But he or she who is last shall be first. So Vincent, we need to hear from you. Tell us a story.
Well, elaborating on Jenny a little bit about what you guys just discussed, working with runners, sometimes, we'll have runners come in and they really like, they just feel tight. And, I've got that, that treatment down a few times where, it's just so simple and so effective, where, the legs feel light, and even incorporating Jianhua, you feel the release of the tension in the hips, and it's so wonderful. So I just wanted to kind of add to that as well.
So you're saying with bladder 37 in the hamstring and bladder 57 in the calf, you're adding Jianhua in the glute medius.
Correct. Yeah. And that's just one of those things that's, it's just super helpful for recovery. It's not like we're going in there chasing trigger points, as you alluded to earlier, how that can generate lots and tons of pain, but ultimately just help for, muscle fatigue, help with relaxation of the overall area, it's reducing inflammation, because I can see a straight leg raise even improve with it. So I think it's a wonderful treatment to take note of and try it.
Yeah. Great. Thank you. And Vincent works at the University of Southern California athletic department, and this summer's been track season. So he has definitely been seeing some runners and athletes. So we do have
can I make one quick question there?
Go ahead.
One quick comment there with when we're talking about, like, I think particularly to athletes, Jenny kind of touched on this a little bit. I'm always careful with the phrasing that I'm using of like a muscle being weak versus like a muscle being inhibited. By us sticking a needle into there, we're not like creating the muscle's ability, like the fiber's ability to produce force like you would through like a strength and conditioning, but we're like initiating the activation of those muscles and fibers. So you can still see this be, it's like, well, how could they possibly have like weak glutes if they're an NFL athlete or Olympic runner, but they can still be inhibited, and we can still make big changes of that force production through these needles. And I think that's like a really important way that I explain to help with the recovery, but also to help with like the potentiation of movement to the athletes and how we're interacting with that. Not necessarily like creating more strength, but creating better activation through there.
Very good point. We have a couple of questions. Can't get away from the shoulder. The best position for the subacromial space. My experience, and I think my colleagues would mostly agree with me, the best position is seated, because when you are seated, you can just sort of think about, let's go back to this one. When you're seated, you can sort of imagine here gravity sort of dropping all this tissue down. You might have just a little bit more space through here, trying to get the needle superficial to the tendon, but deep to the bone. Trying to get the needle superficial to the tendon, but deep to the bone. Seated tends to be able to get you in there better. Seated tends to increase the statistical possibility of needle shock. So there's risk and there's reward. If that isn't the right thing for you, then lateral recumbent. Patient is lying on their side, and you really got to pull the arm down and depress the shoulder. Don't let them lie on their side with their shoulder like this, because you're not going to be able to get into this zone. They can't get like this. Get the shoulder depressed, but in the side lying position. Prop them up with pillows, and that should work pretty well. I said that this is there's lots of ways to go about doing this, but position is, to me, not real negotiable. Face down, prone is not a good position. The shoulder is not in a good position for threading underneath here. So I never put the patient face down or prone into a face cradle. So it's too bad you've got all this other back and scapular stuff you want to treat. You're just going to have to do 2 sets of needles. And so at any rate, there's some things. Do any of you want to comment? Jenny, you want to comment on e-stim settings and what you do? Because there's multiple questions there. And I'm just going to hold up the e-stim 3.
For sure. I just keep it
that LASA OMS carries.
I have a few e-stim 2s and a few e-stim 3s in my travel bag all the time. And I use paper tape to, once I attach the lead to the needle so it doesn't pull it out after I've got it all set up. And then in terms of my settings, I just turn the frequency to about, somewhere in between 8 to 12 hertz. And then I just turn the volume up slowly till the patient feels a comfortable tapping sensation. If it's intense, I tend to turn it back down. And it should be comfortable. It should be something that they could really relax to, in my opinion. And that's what I do for all of the points. I don't mix it up unless I'm using a pointer Excel that Whit showed you earlier. And sometimes I'll do that. I use that sometimes for point location, confirmation that I got my needle correct. And sometimes I use it as the treatment just to, activate that needle a few times but often I like to just, set someone up with needles, e-stim, put it in, tape it down, and then let the person rest for a little bit. 15, 20 minutes, 30 minutes is fine with me, depending on, how much time and whatever else I'm trying to cover in the treatment. Some patients really want their acu nap, and so it's best to, set them up and get out of the room. And some people don't want that. So I think it's meeting the person where they're at.
And I think Jenny is saying that she's using a continuous sine wave, so not doing a dense disperse or a discontinuous wave, a continuous sine wave of microcurrent. That's what I do. I think that's what Jenny is also doing.
Yes.
And the reality is that there's a lot of different ways to introduce e-stim into the body. And I've been at this 45 years, and I do not see anything that tells me that one way is markedly better than the other, that a certain frequency has a affinity for a certain kind of tissue. I don't buy any of that. I don't see that. And until I can really see it clinically, I just won't go there. So however you use e-stim is probably just fine. If you want to use e-stim the way some of us use e-stim, do a microcurrent, millicurrent, not microcurrent, millicurrent. Did I say microcurrent before?
Yeah.
Yeah, millicurrent.
The stem unit will have a little
wave.
switch right here.
Yeah, there's the e-stim 2 with the switch. Continuous wave, turn it up to some sort of frequency or anywhere around 5 to 10 to 12, relatively low cadence or cycles per second. So, but the fact that there are so many different ways people do it tells you that everybody is probably correct. And this I'm jumping around here to Misha's question. When working with the IT band, do you have thoughts on cupping or gua sha? I've heard folks say that can worsen the IT band, and others say it's fine. What have you seen in your practice? Here's a situation where you have two completely different points of view, and both people are right. You can use gua sha, you could not use gua sha. It's not, when there's varying opinions on things, it probably isn't such a fixed, precise way of doing things. I don't usually use gua sha on the IT band because the treatment that Jenny talked about is so effective that I don't need to do that to get good results. But I don't see any problem with cupping or gua sha on the IT band, none at all. So any rate, what else do we have here? I've forgotten. Do you treat the sacrum by needling at an angle, by going through the holes of the sacrum, or are you going off the side of the sacrum? Jenny, you want to talk about the sacrum?
Yeah, for sure. I love treating the sacroiliac joint. So absolutely. Yes, we do treat it. We are not going into the holes. We are going in between the sacrum and the ilium. So if this is the space, like if this is the sacrum and this is the ilium, we're kind of trying to pancake our needle right in between those two. And so we're going 45 degrees oblique lateral and trying to kind of wiggle our way into that space. And sometimes I'll put a needle right so it touches the sacrum, so I know on the bone, and then I'll put a needle so it's right on that PSIS, so I'm right on the bone, and then I'll tuck a needle in between those two in that space. And usually you can get 75 millimeters into that space. And then 2 needles with e-stim. Usually, I had one patient tell me when I did this to her that she felt like she was swimming with whales and there were warm root beer bubbles in her sacrum. She loved it. She's a writer. So like I never thought of it that way, but this was how she was talking about it. So you can see in the area of that posterior superior iliac spine that you might be able to tuck into that space and get in there. Now, one thing to note is that sometimes, and this happens more often in men than in women, especially as they age, their sacrums can fuse. And so you may not be able to get a needle in there. And all of this area has white fascia like strapping over the top of it. So if you feel really stressed about, I just can't get my needle in there, then you can just get it close to where you know it is into that white tissue and connect some e-stim and don't stress about it. And just also you think about that Trendelenburg gait. And can you pull up that slide, Whit, of the Trendelenburg? And Whit talked about the impact of the gluteus medius. So on this side where the gluteus medius is weak and you see the body weight coming down on that leg, of course that's, that lumbar spine is at risk for herniation with all of the body weights coming down on that. But look at what's happening to that SI joint as well. Like it's getting jammed up in there. So probably the person who, with every single step they take, is loading this joint inefficiently for the joint's health. It could be really irritated. So if you put your finger in there and you palpate and it's tender, it's probably a good reason to slip some needles into that space. And we find that, you can get in there usually if you're kind of about 45 degrees oblique and heading laterally, and just try to tuck under that PSIS. So
the trick is the patient is prone, face down usually. They could be lateral recumbent, but the trick is the needle is 45-degree oblique lateral. Ginny and I laugh about this because when we teach this, I say 45-degree oblique lateral about 25 times. And then we go up and everyone's practicing what we've just instructed. And people are going 45-degree oblique medial. And, it's just like, wait, this is just the opposite of what we said. So sometimes it just doesn't quite connect with the brain. So just remember 45-degree oblique lateral. And that's the best approach to get into here, right through there. So,
and the other piece is that, so I said men, their pelvises are much narrower. You're going to be a lot closer to midline in terms of your starting point. Women, oftentimes their hips are just a lot wider, and you may be, much further lateral than you would be on a man. And you'll be shocked. Some women's pelvises, it feels like you could probably insert, 30 needles, and it's just like a gaping hole. And it's just so loose in that area, especially women who've had babies, and, there's been a lot of relaxin in the system. Athletes that are, landing on one leg, like, I would say basketball players, landing hard on one leg, jumping athletes. This can be an issue. So it's a great thing to know how to treat.
Yeah.
But Gen Qua is that it would be an adjacent point to help with this person to load that joint more effectively.
Yeah. Okay, so please, I think you all figured out, I told you to start in the chat box for questions, but of course there's a question box that I'm just not used to live storm as much. So if we haven't gotten to your question, maybe put your question over in the question place, and maybe we'll get to it. I want to deal with this question by Johnny. She thanks for my book. It has been an inspiration. Is there something you feel has changed or evolved since the release of the book, which was 2009, in your way of thinking, approaching, or in treatment methods of the orthopedic conditions? This is a great question, and I can't answer it. So if you would like to write me, email me, and ask me this question, I will tell you exactly the things that I wish I didn't have in the book, and or how I would adjust them. But the important question, this leads to the fact that our group loves Chinese medicine. We have an adoration of Chinese medicine, and we also love sports and sports medicine. And we are on this sort of mission to integrate orthopedic and sports medicine, into traditional Chinese medicine. Mm-hmm. And we have really an unwavering support and trust in the empirical method, in the empirical tradition, that if we do something long enough and we observe these results, we can count on those treatments probably to continue to be effective. So the empirical tradition guides us, and guides all of us. But in terms of these types of treatments that we're talking about, they all come from the empirical tradition. These aren't written in books. There aren't teachers that, 100 years ago were teaching this and we read about them in a book. These are things that we figured out, and by really precisely watching and observing, we've been able to figure out some things. So in that sense, there's portions of my book that I wish I could have back. It's good, but it's not perfect. And there's things that don't exist, most notably posture. In 2009, we weren't quite so hunched and forward shoulder and forward head posture. We weren't quite so bad in 2009 as we are now. So that, of course, would be included. So the human body changes and things change and what have you. But I think the most important thing that I would want back is, I could give the example of the anterior knee here. We've got the patellar tendon, and in my book I talk about threading needles on both sides of the tendon. And there's a number of situations where I think a number of us have come to see that you put needles on both sides of something that's really dense, if it has scar tissue, if it has some sort of thick tissue, E-stem, or the stimulation of the needles, or needle with moxa, however you're doing it, it doesn't get carried into the tissue that has the dysfunction or the stagnation. And that's probably the most important thing that I've seen over time, that some of these types of needles, like for instance, the hamstring tendon, at bladder 36, the superior attachment. Putting needles on both sides of that tendon up there is kind of interesting, but it hasn't been as effective as I would like it to be over time. So we've had to develop new ways to go about things. And I would say in general, rather than threading needles on both sides of a tendon, we would go follow the tendon down to the muscle tendon junction and needle into the muscle tendon junction, the first place that's not so dense that a needle can just slip in there. That's just a general thing. So, but Johnny, if I'm, or Jane could be, if you want to know some details, I'm happy to let you know what I'm thinking about that. So given this, we've gotten this far and we have not even spoken about the neck. So we had a question about treating neck knots and how do you go about doing that? So Vincent maybe has some things to say here.
Sure. Thanks, Whit. Yeah, the question was neck knots seem to be impossible to get rid of. Do you have any ways of getting rid of these knots athletes have at gallbladder 21 and the whole side of the neck on the SCM muscle? So gallbladder 21 through the SCM. So, the neck can be challenging. But I think the first thing we have to think about is the knots and, what are knots, right? Like many people have knots all over their body and they might not even be problematic or they're just there. So when I think of this question, I'm thinking more along the lines of like palpable top bands, maybe chronic inflammation stemming from the spine that are developing, trigger points, or even postural issues, which, Whit just mentioned earlier. So I think the first thing to be looking at is if they're not resolving, versus just needling, I think the first thing comes down to is an assessment and really allowing an assessment to guide you in the right direction. So, observing the patient, how is their posture? Is there a forward head? Are the shoulders rounded? That's something that we see all day long right now. I think with computers driving and cell phones, people are becoming more and more fibrotic, as you probably observed. Also, range of motion is another key component to guide you, depending on what you're looking for and what the signs and symptoms of where the stagnation could be and where the dysfunction lies. So for example, like the upper trapezius muscle, we know that, if you go through there and you find those tight spots, they're going to be there. But what we've learned, and I've learned through experience and, studying really with Whit, of course, Jenny and Derrick, is that needling that area doesn't always provide like a long-term relief. So, one thing to note is like when you're looking at maybe that trapezius muscle in relation to the neck, one thing is to really look at like, is that shoulder elevated compared to the other one? And is that a problem there? Maybe it's something else if it's continuing to come back. So as you can see on the diagram here, one area that's highly, I would say, predictably tight and really knotted up is at SI14 at the attachment of the levator scapula, and even moving upwards into at the zone of SI15 as well. If you ever check that spot, I highly recommend it. And you're most likely going to find something. And oftentimes these patients will have difficulty with like looking over their shoulder, maybe, looking downward. They'll complain it's always stiff, and they'll kind of grab their neck or this area. And then moving upwards from there is the posterior neck muscles and how, their job is to hold the head upright and extended, kind of in that proper posture or ideal, you want to kind of the ideal head carriage, I'll say, and not compressing the back of the neck. Lately, I've been seeing a lot of surfers, and they're constantly on their board and they're looking up, and that posterior neck is it's really kind of a disaster. And they'll come in and say, my traps are killing me. And this really, treating this area to me has been more helpful than treating the trapezius muscle in these types of situations. And you can see the points that are on the diagram. That's bladder 10 at the top on the left. And then down below is by the extra point bilateral. And often bilaterally, this could really help the forward head to come back and allow the patient to extend and get some length and back in their neck, and ultimately take pressure off some of the frontal neck muscles that like the SCM. But moving further, there could be other things going on too. So like when you look at the diagram, this is a great example of like how you can see the scapula and how they're sitting, and really honing in, I think, on how maybe one shoulder could be forward, one shoulder could be back, allowing this to really be your guide, and finding, what could be else, be generating a lot of pain, so, another thing that I've heard Whit and even Jenny say more recently is, like moving further laterally, even checking out where you can see Derrick mentioned earlier, the acromioclavicular joint, where cases where patients were getting needled in the upper trapezius constantly, and then treating the acromioclavicular joint actually helped reduce the inflammation and some of the guarding, that was in the trap, and ultimately helping the neck. So I guess the bottom line that I'm getting at is it's really the assessment is really key, and defining where the dysfunction is, where the stagnation is, and allow that to be a good starting point versus instead of just needling and seeing how things go. I think, the great thing about sports acupuncture is this, testing the patient, doing a treatment, and then reassessing them. And ultimately, you learn a lot, and then also you're helping the patient, because at the end of the day, like, you want them to feel better. You want them to get back out there and do what they love. And yeah, that's, I think if something's not working, we got to think outside the box, I guess that's what I'm saying.
Very good. Very good.
Yeah.
Listen, Nancy says, what are the best tips for safety and effectively needling the scalenes or the subclavius? I have 4 muscles that I don't like to needle. And so I have always a manual therapy person who knows how to needle those 4 muscles. One of them is the scalene, where I prefer hand work. One of them is the rhomboid, the pectoralis minor, which is right up against the lung. One of them is the subscapularis, which is the armpit. And one of them is the iliopsoas, which is going through the intestines and the abdomen to get into the belly of the muscle. So those are 4 important muscles, but I prefer manual therapy, and it ends up in all of the cases, manual therapy is very effective with those 4 muscles. So I don't have any tips on the scalenes. And I'm wondering if one of you all want to talk about the pectoralis minor in trapping the neurovascular bundle, and how important that is, and how we see it, and we have to make sure we can we know what it is. Anybody want to do this?
I can take that one, Whit.
You got it? Okay, good. Derrick,
Yeah.
please.
So similar to Whit, I also don't needle pectoralis minor, but you will come across it being tight, leading to all sorts of dysfunctions, even going back to, so we've got like potential thoracic outlet syndrome. And then just a theme that I think we're all going to echo is this comes down to assessment. So the way that I will assess this is I'll start with what's called Ruse tests, which just basically bring the arm up to like cactus arms, and then you pump the hands. And you do it for 1 to 3 minutes, depending on what text you look at. We're looking for numbness going down into the hand. Many times it's going to be the whole palm and the whole hand. Another way that you can assess this is you can feel the radial pulse. And then if you bring the arm up to 90 degrees abduction at the shoulder, and then maybe a little bit further, once we get above 90, we're putting pectoralis minor under a little bit more strain, so you can really start to put that muscle under tension. If it's already tight, it can entrap this neurovascular bundle that runs underneath the pectoralis minor. If so, many times it's going to lead to that like hands going numb. This could be someone sleeps on their side and wake up with numb hands. They find themselves waking up with the arm up overhead, waking up with numb hands, maybe in an overhead position for an athlete. But we can feel that radial pulse. And if you bring it up into that position, you can notice sometimes you'll start to lose that pulse. The patient will also start to notice numbness within the hand. In those cases, I'm going to think pectoralis minor first. There's scalenes could be involved. We've got like the first rib, in between the first rib and the clavicle. My first go-to is always pectoralis minor, and I'll do manual therapy there. You can needle pectoralis major, and generally I'll needle it and just use handheld stim, like the Pointer Plus. And pectoralis minor and major innervated by the same motor nerve, so you can get a reset there, and sometimes that's helpful without needing to go as deep as the pectoralis minor and start to get too close to the lungs for my comfort. So it's a very simple assessment to figure out if pectoralis minor is worth investigating for this thoracic outlet. Just bring the arm up above 90 degrees, feel the radial pulse. If you lose it, it's decreased, and or they start getting numbness within their hand, pectoralis minor is my first go-to with that.
Very good. And this is very important and very becoming more common, because remember, the pectoralis minor is a scapular protractor. It pulls the shoulder forward anteriorly. And that's the position that we find our culture in with phones and screens and what have you, right? So it's difficult to needle. I love using manual therapy on the pectoralis minor to release it and not worry about the lungs. This looks really easy. But on a forward shoulder where everything is kind of tight and the whole compartment is more close together, everything is a lot more suspect. So you want to be very careful and not assume that this is how your patient looks with all of this empty space very safely lateral to the ribs. So manual therapy I like very much, but also remember the simple aspect of reciprocal inhibition, right? Yin-yang muscle. So if the pectoralis minor is pulling the scapula forward, protraction, let's go to a scapular retractor, a muscle that's pulling the scapula posteriorly. And those are yin-yang muscles. And when you stimulate this muscle, the rhomboid minor, it may allow the pec minor to release, to relax, because they're yin-yang opposite muscles. And sometimes this is a great treatment. This doesn't really quite have a point name, maybe 41, bladder 41, 42, 43 are up against the lateral, it's the lateral bladder meridian up against the medial border of the scapula. But palpation will help you find the rhomboid minor, and it's almost always level with small intestine 13. You find small intestine 13 in that fossa, that bony fossa, and just go toward the spine and you will reach the rhomboid minor. So a lot of times I will add that to helping to release the pectoralis minor. So we've got a couple of little questions here. One of them, E-stem for plantar fasciitis. Question mark. I use E-stem for plantar fasciitis most of the time, but it runs the risk of aggravating. So sometimes it will cause an aggravation as you're moving the chi in the blood and it just doesn't drain. It doesn't move fast enough. And so more is coming in than going out, and you've kind of inflamed the tissue, and you got to wait a day or two, and the patient doesn't like it. So there's tricks to try to keep that as minimal as possible, and you could choose not to use E-stem, but I like E-stem on plantar fasciitis. Another question, moxa on needle. I like a moxa on needle. You wouldn't just have to have a metal handled needle, right? Not a plastic handle, so no sarin, but get moxa on needle top. You're driving heat as a form of energy rather than electric current as a form of energy, rather than mechanical stimulation as a form of energy. There's lots of ways to stimulate the needle in the tissue. And moxa on needle is totally acceptable, whether it's a hot condition or a cold condition. But if it's a hot condition, you're certainly not using a stick moxa and just heating up the whole place, because that's when you can really kind of shake up and stir up a pretty good problem, aggravation. My friends, we're running out of time, but Molly says, I currently work for a pro team in a state where dry needling is allowed. When you face this dilemma, how have you handled it? What sort of education do you present to separate us as the needle experts? And every time we talk, this is always a question. People are stymied by the dry needlers. We're treating patients that dry needlers have just aggravated the heck out of by not precise and really delicate and elegant needling. So it's a big issue. Please, Jenny, you know a lot about it, but each of you probably have an opinion. So what do you think? How do you deal with it?
Gracefully as possible, with respect to the other people that are working with the athletes. So I was working at a sporting event where other people were also working the event. We're all together in one room, a lot of PTs in there. And one of the athletes on the table said, he screamed across the room, because he was on a table a couple tables down from me. He said, Jenny, what's the difference between acupuncture and dry needling? I always wondered. And then just silence in this whole room. So, and of course, everyone's using the same tools as me, and chiropractors and their personal physical therapists, and they're, we're needling a lot of the same points. So my answer in in that domain was, it's just a different matter of training. Sometimes we're using the same points, but we may have different techniques in our approach and how we get to it. It's also a matter of billing, and it's also a matter of user experience. So there are acupuncturists who handle a needle without a lot of grace or skill, and there are physical therapists and athletic trainers who handle a needle without a lot of grace or skill. But, acupuncturists are working with the needle all day long, and tend to have the opportunity to develop a level of skill that can make the treatment very comfortable for the patient. And I will say that what I was asking the athlete that invited me to work at that event, why are you having me come out here when there's lots of other people who are doing this? And he said, well, and I said, and I see them working and they're doing the same points. And he said, well, it feels different. So, okay, it feels different to the athlete. So, as gracefully as you can, because these are people that are going to be referring back and forth to you. And all the athletes are talking in the locker room about what their experience is and what worked for them. So don't worry about what other people are doing and just handle your business and get good results and focus on your treatment.
Very good advice. It's pretty difficult to try to go up against this thing. We're not going to win the battle. We're not going to win the war. Other people are going to be able to use needles for dry needling in some way, shape, or form, no matter how much resistance we put up and no matter what argument we try to present. And in the end, we need to get good results with what we do, and that will speak for itself. I'm not involved with the politics of this, and I won't get involved with the politics of this. But fortunately, there are people who are trying to stand up for acupuncturists' kind of right to use the needle, and a sport trainer shouldn't have the right to use a needle. We know that, but I just don't think it's worth putting the energy into conflict when we can put it into getting better and having our results speak for themselves. So that's my opinion there. We're pretty much getting toward the end of our time here. Do any of you three have anything else? Any just little gem of anything to add or to elaborate upon?
I've been, there's like a general theme that when Vincent's answered questions and Jenny's answered questions, when we're talking about the pectoralis minor, right, when we're talking about the IT band, we're talking about the upper traps, these areas that commonly are the ones that are like screaming out for attention. And if you guys notice, many times with that, especially if it's stubborn, like this, chronic knot at gallbladder 21, the approach that Jenny presents when Whit was just talking about the pectoralis minor and the rhomboid minor with the IT band and TFL, but glumin, oftentimes you don't have to go right to that aggravated area. If we can think of how this system works together, if we have the IT band that's overloading, we can assess and see, okay, do we have uneven hips through here? And sometimes, you need to go right to that stagnation point. But if we can also think of these other things, the upper trap, one of its main duties is to offload stress from the cervical spine. So Vincent spoke about it. If this is constantly tight and we keep needling into that and not getting any results and we're just treading water, there's often something else that's going on. For the IT band, if we're just constantly cupping IT band and just keeps coming back, oftentimes there's a lack of hip activation coming from gluteus medius, gluteus minimus. So thinking about these things, and I think as acupuncturists, we're like set up to think about these things. Like we have these, the 5 elements and the controlling cycle and the generating cycle. These things weren't taught to me, like that way of thinking wasn't taught to me within the sports medicine world. It was going to acupuncture school that made me start thinking about these things on like a cyclical and relationship way. So we're already programmed to think about that. I think if we can understand assessment and anatomy a little bit, well, that's how we're going to set ourselves apart, from the dry needling, people that are just going in and needling the IT band over and over and over again, to start thinking about these things through the generating and controlling cycles through movement. As I was listening to, Jenny and Vincent Whit, talk about this, that theme just kept coming up. where it's like, think one step further, not just going right to where that like local stagnation is, but start thinking about like, okay, why is this present? And how do I assess to figure out why it's potentially present, and how do I change that?
Wonderful. We need to turn this back over to our friends that we love and the company that we really, really have a wonderful relationship with, which is LASA OMS. I just want to make sure Vincent doesn't have anything that you wanted to add before we turn it over to our hosts.
Thank you. I think the main, just to add on one quick thing, is just remember it's all about practicing. And as Whit said, it's very much empirical medicine. We're learning day by day, and each day you'll learn something. You're going to build upon that, and it's going to build your confidence. It's going to build your understanding of the medicine. So just get out there and practice and study along with it, because this is forever.
Yeah. Beautiful, wonderful. Robin, tell us what we need to know here.
Yes, thank you so much to our panel of experts, and thank you all for joining us. If we happened to miss any questions, feel free to reach out to us at marketing@lasaoms.com. We're putting the webinar or the promotion code on right now with a link, and we will also send out an email with that code. Again, it's WR webinar 724, and you'll also get a link to view the slides. Thank you again for joining us, and we look forward to seeing you all at our next webinar.
Bye-bye. And thank you, Robin. Thank you, LASA OMS. You all are doing a great service.
Thank you.
We appreciate it.
Thank you, everybody.
Yeah.
Thanks, LASA. Thanks, everybody else. Thanks for your questions. It was really fun to see everybody log in.